Good afternoon. This is the Oregon Health Authority. We have the project team here for a presentation today, primarily on the final rates and capacity reporting. With us in the room are
Rick Wilcox,
Michael Oyster,
Carmen Armendariz,
Tricia Alders,
Key Brazier,
Elise Campbell.
and I am Sharon Hill, the project manager. So I'm going to give you some just updates in terms of the implementation and try and save plenty of time for Rick Wilcox and Michael Oyster to share with you new and emerging information that we're sending your way. First of all, on the first slide for the July 1st implementation, I wanted to reinforce to everyone that we had requested and sent out a template early last week for all facilities to submit a updated client roster with the LSI scores that you as the provider and your local CMHP will have reviewed, so that we can figure out what the tier is and literally update and create the new rate effective July 1 and work with KeyPro to do that before we go live on July 1st. So we need those by tomorrow. It's the usual mailbox, the mentalhealth.residentialtransition@state.or.us. That email address is also on the last page of the presentation, which we will PDF and send out to you after we finish today. The second piece, and you'll hear more about this, is that we're going to begin to do the full roster capacity report that will be due next Friday. It uses, essentially, it builds off of the template that we sent to you for the roster due tomorrow. And Michael is going to review that with you later in this presentation. We're working toward having that weekly report, so more to come from Michael. In terms of the rules, I want to remind folks that June 18 is the public hearing for the proposed rules related to residential rates. So if you have comments, you need to make those official comments. You can attend the public hearing, but you can submit written comments up to June 20th. The piece that I highlighted on the next page for rules is the last bullet, which is once these rules are finalized for the end of the month, we are in the process of drafting temporary rules that will deal with the concepts that Rick and I are going to talk about during this presentation, where it's Tier 5 language and intensive services criteria. So stay tuned, and we will work with you on that temporary rule as we will establish some initial criteria and keep working through that. But that process will not be filed until we finalize the first rule, the final main rule, and then we have to do a temporary behind it. In the meantime, though, we will be discussing the issues with you individually and collectively. What I heard on the next slide for the standardized rate overview is, while we've had provider rate calls since March and April, and the prior webinar in May, it sounded like folks needed a refresher around how the rates were developed. And first and foremost, I want to call your attention to, I skipped over the what we're covering. You want me to back up? What we're covering is literally the overview I'm doing now, the standardized rates, the special programs, and then which Rick and I will go through, and then the capacity reporting, which Michael will go through. So the feedback on the standardized rates is, it felt like people assumed that the rates were based on a minimum wage. And I wanted to back up and encourage folks to go to the website that's referenced here. On our rate standardization webpage with OHA, there's the December 5 presentation from Optimus. And Steve Schramm from Optimus did a great job of explaining and walking through the whole process and how we got to things. But I do want to clarify, and so I literally have inserted some of Optimus's slides into this presentation as reference for you, because I want folks to get back to how we created what we call the brick, based upon the information you as providers have submitted because of your general ledger, and then how we built it to create a standardized rate. And then ultimately, at the end of that, we adjusted it for a number of things around bed capacity, around geographic variation. And then out of all of that, Optimus helped to make sure we trended it to stay at pace with the minimum wage. So it isn't minimum wage that we're considering, it's that as Oregon's minimum wage increases every July, can we adjust for that? So this first rate on July 1st is literally trended to the rates for Oregon's minimum wage as of July 1, 2019. So I'm going to go through that a little bit more, and just, these are Optimus slides. And so I'm not going to speak, I really believe you need to go back and listen to Steve's explanation on the December 5 presentation, but how they approached getting the general ledger data from you all, and then how we then constructed it in terms of what we call the brick, which is their way of developing the standardized rate. The piece that people may have misunderstood, and so that's why I put in slide 7, where you provided general ledger data, and then based upon the conversations that John Villegas-Grubbs had with providers around what your jobs classifications were, he actually went to the National Bureau of Labor Statistics to figure out what kind of wage, what kind of classification your direct care workers were. And so he created the general ledger. I'm going to skip over slides 8 and 9 because it's just, again, I'm really encouraging you to go back and listen to that presentation. The one I want to draw your attention to is slide 10. And from the conversation that John Villegas-Grubbs had with you all, he identified that the home health aide with a Oregon wage of $12.45 and the personal care and service worker with the wage of $16.51 were the two closest job classifications to what you all described as your direct care workers. So those are the ones that they bundled together to put into the cost formula in terms of what that looks like. So the wage data was then aligned to the time period for when you sent the cost data, which was most of your data for general ledger was 2017. When they finished all of that brick, he trended it forward to the CPI for July of 2019. So I want to go through that and make sure that people understood that this brick, it does not presume that this is predicated on minimum wage. It wants to keep pace with, but it's considering job classifications that are higher than minimum wage. That doesn't say anything about how you actually employ and what your rates are, but we took that into consideration in terms of how we set the brick up. So that was a long-standing question. I know I got questions from folks during the Provider Association meeting last Friday, and I wanted to repeat that. And also we've had a lot of folks now starting to see what that means with their rate. And again, if I haven't said it before, I really would encourage you to take the time to listen to Steve Schramm and the Optimus presentation that you should be able to link to on our rate standardization webpage. The other pieces to note, and again, it's Optimus slides, is there's the engagement brick in terms of what there is. There's a separate slide in Steve's presentation on the supervision, so that the rates are a little bit different based upon how much your staff is involved with engagement versus supervision. And so all of these pieces built this standardized brick that we work on. After we built that brick, after Optimus and JVGA built the brick, we were talking about the different kinds of costs. Another piece that came up in the Provider Association call, and also previously from other folks, even back to the initial presentation in December, is that there wasn't a lot of cost variation across the state. There was a slight cost variation for Tri-County because logically in terms of housing costs and that sort of thing. But even in the Tri-County, you would have neighborhoods where it was really expensive and there happened to be a home that really the cost had gone up significantly, but across the street, it might not be the case. So there was not enough of a consistent pattern. Regardless of that, what we felt going forward and what we and OHA leadership agreed on is that costs are not just about wages, it's about housing and it's about transportation. And any and all of that is varying even in rural areas throughout the country, including Oregon. And so we wanted to figure out how to approximate that going forward for future kind of adjustments of the rates. That's how we actually decided to leverage the fact that Oregon has the minimum wage, the regions they have, the CPI that they raise every July. And so that's how we determined to use the geographic variation that's based on that. So a couple of concepts where we're trying to be forward thinking, and we just want to share that information with you. And again, I'm looking at the information here. Part of this, as Steve's presentation goes through, what you'll see on slide 16 as you get it, is that we kept asking, what else would show differences in cost across the system? You have homes of 5 beds or less, and then you have facilities anywhere from 6 to 16. And we ended up looking at the data to figure out what's the economies of scale and what that means in terms of the rate. So again, that's another reason why we looked at capacity and economies of scale to break the rate down and give it a little bit of support for what does it cost to handle a group of 5 as opposed to some, there's a common size around 8 to 10. And those costs are a bit different than running a facility of 13 to 15. And so we were doing those pieces as well. So it was pretty complicated, but we thought we tried a number of different strategies to make sure that we could account for the variations of all of your programs across the state. What we found once we did the rate simulation in December was that we had a number of programs, 3 specifically, that we felt it wasn't an anomaly so much as the rates that were drafted working with Optimus felt like the secure facilities. There must be some staffing that we might be missing. The same thing with the young adult programs. And we also knew that, and this has been the issue we continue to struggle to approximate, is the ones where programs and individuals with really high levels of care need, how do those get adjusted for or accounted for? And the first thing we were able to do with both secure and young adult is go back to our rules and our programs and validate that their staffing ratio, their engagement hours, the credentialing that's required in those 2 specific programs were distinctly different. Even though they didn't show up in the original general ledgers, everybody's ledgers were essentially similar. And so what you found is that there was clinical and rehab that were embedded in these programs that weren't true in other programs. And so Optimus worked with us as we validated that data. And so anyone with the secure or with the young adult program is going to have the same tiered rate, but the way the standardized rate is built in the brick, Optimus can help us to adjust for the fact that there is an increased staffing ratio. And that's what happened for anyone with an SRTF or a young adult program. So the reason I'm telling you this is to start to transition toward Rick's piece, because what we did, this last piece that you see that we talked about in May and we put into the final rate is that except for SRTF and young adult, we had Optimus create with the data we sent them for a higher level need of client, that there's a tier 5 where it really assumes a frequent monitoring and redirection, and that so more staffing would be needed, the ratio and the engagement would be increased. And so they had adjusted that, and that's how we came up with a tier 5 rate. We still feel like there are other issues that we're raising because we notice in some of the programs that we have, someone might be at a lesser LSI assessment score, but because of their traumatic brain injury, or their severe diabetic neuropathy, peripheral neuropathy, or they have a personality disorder that really complicates treatment and self-care, that what is it we need to do that we could use the Tier 5, what's the criteria, and what are those last groups of people that are not necessarily outside what we've built, but their conditions have such complexity that we need to look at them differently than here's your LSI and it's associated with your personal care service plan, and those should approximate the standardized tiered rates. So what we are working toward, in addition to Tier 5, is an intensive services process. And this is where I'm just going to tee this up for Rick, that there's 3 different ways to look at this, excluding SRTF and young adult. One is if they're LSI 80 plus, and that's a straightforward one for anyone that's got those clients. The second is you may have individuals with lower LSIs, but these require frequent monitoring and redirect, and you have multiple medical conditions that are creating those kinds of complexities. That needs to be reviewed. And if there is any other way that we want to make sure that we can individually, case by case, if necessary, if somebody doesn't fit into A and B of that, then again, we want to use that same process in B to figure out what else are the needs of that particular individual and how else can they be met, and is there something else we need to do. We understand from Optimus that we can cover 85 to 95% of these folks. That last group of 5 to 15%, you have to have some adjustment and some individualized process. And that's the piece that I'm giving the easy softball over to Mr. Wilcox to share with you what we're developing.
Okay, thanks, Sharon. Before I start that, I see that there's a question. CPI, that stands for Consumer Price Index, yeah?
Correct.
Oh, you did, okay, sorry. Okay, so can we get the next slide? Okay, so as Sharon said before, the BRIC method can account for 85 to 95% of the folks, but regardless of how thorough and comprehensive your standardized assessment process is, there's always going to be a minority number of individuals who have issues that really aren't captured by those standardized instruments. When we pay, and we used to call them enhanced rates, but we prefer to call them intensive service rates now, there's always been some kind of, we've in a lot of cases lacked firm criteria for these intensive service payments. Previously, we were negotiating based on stated costs of the program, but what we want to move toward now is to retain our focus on client acuity, just like with the BRIC and the levels, but we also want the intensive service rate reimbursement based on a fixed rate as opposed to a negotiated cost. Next slide, please. Okay, so we don't have our process fully outlined yet, and we don't have a rate settled on yet. There's a lot of different things we're still taking into consideration about a rate, and I'll get into that later, but we're getting some feedback from you all about things to consider when we establish a rate. But the intensive services rate request based on medical needs, at least one-to-one full assistance, we need one or more of these. Use and maintain adaptive or medical devices, assistance with catheter or ostomy care, delegated nursing tasks, feeding, mobility transfers or repositioning, toileting, bladder or bowel care, or severe risk for wound care. So those would be some of the medical things. So this would be more than just somebody having, say, simple diabetes. This would have to be somebody who was very brittle and had neuropathy perhaps, and had some skin conditions as a result of that. That's an example. We can next slide for behavioral. Okay, intensive services based on behavioral, psychiatric, or cognitive needs, one-to-one supervision in excess of 7 hours a day, more than one-to-one supervision to maintain community safety, communication deficits requiring substantial intervention. So this might be one of those individuals that has a mental illness, but also has developmental or cognitive disability, but is not eligible for services, for DD services, but they still need substantial communication assistance to understand what's being told to them and help them moderate their behavior, or a documented pattern of decompensation without the proposed intensive support. So this intensive services rate population, with some exceptions, I kind of think of them as these are currently the individuals that providers are asking one-to-one assistance for. Go ahead, next one. So the process at this point is the provider contacts the rate review committee and submits the required documentation. The committee will review that and meet with the provider. And it can be a phone meeting, it can be an in-person meeting. We also want representation from the county, the individual in question, or their guardian or representative, so that we can all have a collaborative conversation about what this individual's needs are and how best to meet them. I doubt that the IQA would be, can we go back just a second? Okay. I'm not sure the IQA would be a part of this discussion, but we would certainly be consulting them on the front end after they came to do their review. Okay, so we can go with this. Okay, I know the font is small, but I wanted to get all this stuff on one slide. So obviously, most recent LSI and locus, current treatment plan, current person-centered service plan, current mental health assessment, current history and physical for rate requests based on medical needs. If it's a psychiatric or cognitive need, we don't need to look at that. Current risk assessment if applicable, relevant incident reports, last 60 days worth of progress notes, a one-page explanation of how the proposed services meet the needs identified in the person-centered service plan, because as you know, this is how we do our Medicaid payments. It all references back to the person-centered service plan. A one-page synopsis from the CMHP or choice contractor affirming the need for the proposed services, and to complete the intensive services rate determination request form, which has not been designed yet. We are not ready to go live with this. We want to see how the rolling out the rate standardization and the tier 5 works, but I anticipate we will be starting to field these within several months.
This is Sharon, the ad that I want to give right now is that this list of documentation, whether we have the form or not ready, what we're literally looking at for you is if you have a client that is not an 80+ LSI that you think meets the criteria that Rick just went through, our basis as we proceed while we're looking at this is that use this documentation to show us what the need is, and we'll look at it whether tier 5 makes sense based upon what we're understanding with Optimus about that requires more staffing, it requires more engagement, because those are consistent. So we want to use the process that Rick is outlining here. The challenge and the piece that we need to look at going forward in the next several months is, does this adequately qualify somebody up to a tier 5 rate? And if not, that's the piece that we're going to have to work with people individually to figure out. If not, then what are those needs and what does that mean? So we really are hoping that A and B are about addressing the bulk of your issues, and if not, we will use this process for both the lower LSI that might be a tier 5 or the lower LSI or whatever that just has so many complications.
Certain things that aren't captured by the LSI or the locus. And I see a question, is the locus going to be required now? The IQA is going to be doing both of them. So you guys don't have to worry about completing those. There was a little bit of, I know last year or a couple years ago, we came out with the announcement that the locus was no longer required, but it was still in our state plan. So we, but again, IQA will be doing that, so you don't need to worry about it. And if for some reason we end up not doing it, then you won't be required to do it. We just want a comprehensive look at this individual and their service needs.
There's another question. It says, is KeepRoll completing all person-centered plans now, or are providers still expected to be completing these?
During the transition period for the rest of this year, we're expecting providers to continue to work toward that. The RFP process is in play, and there will be a transition in terms of the contract requirements, but for this next 6 months or the first 6 months of rate implementation, we want you and the CMHP to continue doing your work.
Okay, so the next,
Let me move on.
next thing?
Yeah. So the advantages to this process is we have a standardized, transparent process. We have specific, clear criteria. It gives us an ability to better collaborate with providers, counties, and the IQA. And we want to maximize, we want to eliminate as much as possible providing general funds for Medicaid eligible individuals. And so,
I think then are there questions you need to answer?
yeah, no, I think that's similar to the last question.
All right.
We got.
Yeah.
Yeah.
So the transition, there was a question that people posed recently about what the transition guidance on the next slide.
Okay.
So similar, and we've said this for a while, similar to what we've been doing with the early adopters, there's a transition period where we need to require that there's daily documentation. Medicaid services require daily documentation. And so first and foremost, we need to get folks on day one, there needs to be at least some recognition and note about what was done with the client. We've done some presentation earlier in April and May around linking the kind of golden thread, and I'm going to throw it over if Michael or Rick want to add to that, since it was their presentation, that there's some documentation that links that also up to the diagnosis and the person-centered service plan. So that should be straightforward. It may be a change for folks, and so operationally, things need to be put into place, but that's certainly a day one sort of thing. The other piece with this is that residential treatment homes and facilities are distinct from adult foster homes and others where there isn't treatment, there isn't engagement. There's 24/7 for a reason for our individuals. And so that engagement may also take some time to develop, but the point is, what is that engagement piece and how do we build on that? We've had wonderful progress and exciting progress with both the early adopter staff and the early adopters individuals in their response. That's not to say that there weren't experiences where the providers reported that there were individuals that didn't want to participate. And how do you kind of work with someone who doesn't want to participate and be sensitive to what's the person-centered service plan, what's appropriate clinically to kind of engage someone or get them to engage, and that it takes time. We understand that. It is very much individual and situational, but the requirements to move toward documentation on day one and engagement and just growing that over time with the client, because it's a new kind of environment for a number. But those are the expectations as we move into this new system. So I just wanted to clarify that for folks. And then next slide, I think we're going to turn this over to Mike.
All right. Let's go over this slide before turning to the actual spreadsheet that you'll be using. Really, this is a roster to report all of your clients beginning on June 14th to this address, ABH Residential Capacity Reporting at dhsoha@state.or.us. That is the proper one. The improper one is actually on the form, and so I'll change that. And then after June 14th, there should be weekly reports for new admits, any changes to LSI, transfers, discharges, And even those who are, there's no change, you still want them on the list. And I'll show you how to do that. Just a couple points before turning to the spreadsheet. Be sure that if there's a drop-down list, that you use it. Do not enter things in the drop-down list categories, use the drop-down. In the instructions, and I'll point this out, there's enter categories and select categories. Enter means you type something in, select means you use the drop-down list. Do not edit the lists, but do give us feedback about them. This is the first version out. There's already a few things that I've noticed that's a little bit askew, and that's fine. That's where we're going to start, and we'll make it better over time. So please give us feedback so we can improve that. Every client should be included. Both resident and referrals should be included on the list. And then, of course, be looking for new versions. There is not only a date, but a version. This is version 1.0. This allows me to have multiple versions per day if that is needed, which, you know, sometimes that's needed. So with that, if you could help me get to the spreadsheet itself. Excellent. Thank you. All right. So here's the spreadsheet that I think you already have. Notice that there are two tabs. The first tab includes the instructions. Now, I will change this email address because I incorrectly put it in there. And yes, I'll change the spelling of capacity because that's not spelled accurately either. And you may find some other errors, but these are the instructions. Notice the enters and the selects down here. This is your reference list. This is all that there is. So there isn't actually too much in here. And you don't have to memorize this too much. Let me just go through the spreadsheet so you know what we're talking about. The reporting date is the date that you are going to be filing the report. So for today, that would be 6/6/2019. Client status, notice this little box right here. See, over here, we didn't have a box. It was just a blank cell. Here, we have a drop-down. So you want to use the drop-down, and here's your choices. Either a resident already in the program, or a referral, a person who has been referred, who is on the wait list. Okay? Next one is the name. Of course, there's no drop downs for this. The last name, first name, middle initial. Date of birth is the same kind of date. This is not spelled out. It would not be June 6th. It would be 6/6, right? So it's all numbers. And then also the Medicaid number. If the client does not have a Medicaid number, then leave it blank. If you now, these are rules, right, that I'm kind of going through, but those instructions are right back here. Medicaid number, enter individual's Medicaid number, or leave blank if not Medicaid. Okay, so that's what those are there for. Let me move this over.
And Michael, the point of the not Medicaid, leaving it blank, we want capacity for everyone. So if they are a non-OHP that's in the residential home, we need to know that.
That's right, or a referral. Who's not Medicaid, then that would just be blank.
Exactly.
Yep. Home CCO has a drop-down box that appears when you click on the cell, and here's all the CCOs. Clearly, as things go on, we'll be changing and updating these lists, but this is what we have for right now. And notice right down here, I'm not enrolled in a CCO. All right. Counties, same thing. Once again, a box comes up when you click into the cell, and here's all the counties right in here. Legal status also has a drop down. And notice these aren't all legal, but they are what fits the category. Notice we don't have like other here. The reason is that we have to select one. If one is needed that's not on this list, give us some feedback, and we will certainly include it on the list. But we don't want to have non-categorized. So if something doesn't fit, don't put your own description here, use your best judgment and select one from the list and give us feedback. LSI score, you just write in, type it in. Right. We can't write with a pen. Use pen, not pencil, right? And then here we have the guardian name. This is probably the first time in our system that we are requesting guardians. And this is really important. It's important for you as a residential provider to know that there is a guardian, if there is one, because you need that guardian's authorization to provide treatment. So you should have the name and the contact information. This contact information can be phone number or email, and you would know that. If you came here and said enter guardian contact information, email or phone. Okay, so if you have any questions, just go back to this tab one. This category, the green area, is yours. That's all client information stuff. You have to select a residential type before you can select the name of your facility. So you select the type, SRTF, and then you will notice that when you click here, the drop-down is all SRTFs. Okay? If, on the other hand, you were in a residential, then this category ends up changing to only residential. This is called dependent columns. Very handy so the lists aren't so long. What you will notice is if for some reason you get excited and you skip to the name and you don't have the type and you try to select a program, it won't let you. You have to choose one over here before you proceed. So a good rule is just fill out the form left to right. Admission date type is very similar, in fact, is exact to the legal status. These should match. It's possible, hypothetically, that they wouldn't, but they should. Again, if I've missed something here, please let us know. Here is either the admission date or the waitlist date. If they're a resident, it'd be the admit date. If they are a referral, then it would be the waitlist date. The decision that they are good for the program and being placed on the waitlist. When a client discharges, this is where that date goes. Disposition is a drop-down as well. These are categories, notice, not necessarily specific things. So this is supportive and supported if you were to select on that. Oops. Move that over a little bit, then you would get supportive. There is not another category here. You select one of these. Other doesn't get us the information we need. So it's important that you tell us what that is. Also, it's important that you select the category that the client goes directly into from residential. So they might have gone into, let's say, an acute hospital and then into the state hospital. You would choose acute, though, not the state hospital, because it's the disposition directly after residential.
From the discharge date.
Right, from the discharge date, which is also described, of course, over here, when first leaving the residential treatment. So really, that's it. So each week, you would already have, you know, after the first week, you would already have the list. You just change the date in this category here, and you update any status. If I were you, I would change the name so we know where it's coming from, and then send it over to us.
That was my question, is we need the name, either save it there, or how do we have a place for them at the top, maybe the first line or something, so they have name and Medicaid ID?
The program name should be identified here.
Okay.
But I would encourage you to do a save as here and just add your name after this.
The name of the home, the program.
Yeah, not say program name, but say your own program name, and then it's very clear to us whose clients those are.
Okay, great.
All right, I've been doing all this without my glasses on, so I have no idea if there was any questions.
And we should perhaps, again, this is, we're working on this going forward. Excellent, Michael, thank you. Do we also want to have the week of reports? Because once things start coming in, what I'm concerned about is people who are delayed reporting may get into the next week, and I want to make sure that we can clearly know where capacity is for everybody at a week's period of time.
Right now, I tried to pick week, like week 32, right? Week 33. I wasn't able to do that with this version. Okay. I will continue seeking that to make it clear which week we're talking about. Right now, be sure that you include the date that you are updating the report, and that report should be weekly.
Yep.
So, and what I would also suggest is make it the same day of the week every week.
Yep.
So if that's Monday, Friday, Wednesday, whenever, the same day of the week, and just stick with it. Okay. And then you'll have a record of each of those weeks, and it'll be easy to track then.
Okay. And then the plan for us internally with these reports is to basically build out a system-wide weekly snapshot of who's where and where are the open beds. Yes.
So you can see how a client could be referred to, let's say, 3 different programs. We'd be able to define that. We'd put in the client name or their Medicaid ID, and the 3 programs that they are on the wait list would come up. We would select a particular week range that we would want, and we could identify that. We could identify trends of when a person went into acute care, when they came, to another residential, when they moved into, different programs. So when they left and where they went to.
Mm-hmm. Okay. Are there questions about the template? I did send out to the distribution list this morning this version of the template so people could be familiar with it as Michael went through it. You'll make a couple of changes, and when we send out the slides for this presentation, we can send the template out with it again.
Yes.
So everybody has that. All we've added from the roster really is instructions and the green section and the additional areas. So the work you do this week for the roster update, you should be able to carry over, that we're not substantially asking you different information.
Once you have your client list in the report, it'll be very easy just to change the elements.
Yep.
But you'll want to review each and every client to be sure the information is correct week by week.
Okay.
So there's a question. We have 3 different houses. Do we submit a separate capacity report for each house, or can they all be entered in one?
That's a great question, and I'm sorry I didn't put this on the slide. Each house, each setting should have a separate report. I realize some agencies have multiple settings, and it'll be important for us to distinguish which setting by name each client is at.
Does the June 14th deadline replace the previous June 7th date for submissions of rosters and LSIs?
No. We need the rosters and LSIs as of tomorrow so that we can work with KeyPro to get everyone's plans of care updated with the new rates, with a new line for effective July 1.
Who is the best contact for questions about the completion of the LSI? Especially how each item is interpreted.
KeyPro at this point, I think.
Okay.
KeyPro.
KeyPro?
Yeah.
Okay.
Yeah. Will this form replace the weekly report census that is sent to KeyPro currently?
Not just yet. That census report that goes to them monthly, we haven't talked about that part of it. A part of it, because we're doing the IQA transition with the RFP, it will replace for those providers, and I was going to send out a separate notice, have been reporting on the mental health residential. They've been giving us the weekly roster. This would replace that. But we need everybody to participate so we have an entire system-wide understanding of capacity. The people who have been diligent and reporting at that roster will shift to this.
Okay.
The same question. What if the county has more than one CCO?
The CCOs and the counties are not contingent like the program type and name. So it will be able to handle that. You can select the appropriate CCO. The CCO now should be the home CCO of the client. And that's especially important for residential treatment because it doesn't get flipped. It doesn't get flipped to the local CCO. It goes on the client's home CCO by home CCO rule. And then you choose the county that's aligned with that CCO.
Is this report in addition to the current choice report?
Yes. The choice report, eventually, this report will end up saving time for other reports as we merge them. But right now, they're not yet merged, so the choice data report monthly will still occur.
Would we need to report referrals that are under review or not appropriate?
Rick says yes.
Yeah, I think so, because what we're trying to do is get a handle on the flow in the residential system.
Yep.
So, you wouldn't have to go into great detail, I suppose, but.
I am assuming a client might admit under a civil commitment, say under trial visit in non-secure program, and then become voluntary when their trial visit expires. Would this be an example of these two items having different entries?
I'm sorry, could you read that again?
I am assuming a client might admit under a civil commitment, say under trial visit in a non-secure program, and then become voluntary when their trial visit expires.
Yeah.
Would this be an example of these two items having different entries?
Possibly, or it changes over time, right?
Mm-hmm.
So over time, that certainly would change. And potentially, I could see how that could have different entries.
Okay, so the next questions are the same.
Okay.
For waitlist individuals, is that the entirety of the county waitlist, or those who are potentially moving forward to admit within a specific time frame?
It would be by home, by setting. So in a county, there could be multiple settings, if that's what you're asking.
Yeah, I'm a little unclear. Are you talking about some kind of universal county wait list, or, because we're trying to track
Some counties,
flow,
Some counties
control that. I know, we're trying to track flow, though, for specific
the home.
programs.
right. So for counties that have a residential coordinator, they may help to organize some of that, but each setting should report anyone who is on the wait list for that setting. So you really want to be focused on the setting, not necessarily the county. It should be that in the end, the whole county's wait list should be accounted for through this reporting. If it's not, then we've done something wrong.
For referrals, programs don't always learn the disposition. Will this entail a change in the process? Will programs need to learn this information?
Yes, you need to know where the client was planned to go, and you should get that information from either Choice, PSRB, or Aid and Assist.
So this is a follow-up question from, we have 3 homes. Do we need to use one sheet or
Yes.
more?
3
You have
reports.
columns on the spreadsheet to capture the specific houses, so why do we need to separate the reports?
Well, because we want to be sure that each setting has clearly given us the weekly report. It's hard to distinguish that with combined kind of reports. You do have a point, and we'll be able to easily separate that out when we're combining all the reports. But we want to have a tracking system so that each setting is giving its own report.
Do we enter Kipro's LSI score, or what we determine the LSI score is?
Okay, if you have the IQA's LSI score, that should be entered.
That's the official.
That's the official, and in lieu of, say, the IQA not being able to get to do that, then we're depending on the choice contractors or the CMHPs. We're really, during this transition period, we are accepting provider-generated LSIs, but in our state plan, it's very clear that it has to be an independent third party. And so we want to move away from that as soon as we possibly can. And
Right.
so just to reiterate, if there is a Kipro LSI or a CMHP/choice LSI, that's the score.
Will we need to continue to enter MOT data that is the same as a capacity report?
For right now, yes, you'll still have to report in MOT. It's for a different purpose and a whole different database. We hope over time to be able to make these databases relational, but right now they're not.
Yeah. This doesn't have to do with your form, but should we answer?
Rick?
Yeah, we can answer that. Well, we've tried to communicate that, yes.
Let me read the question.
Yeah, go ahead.
Okay. So do these rates only encompass T1020? Do they include HK billing? What about the bed payments and rent subsidies that come through our allotment payments?
Okay, first of all, the rent subsidy and any GF payments that you're getting through counties are ceasing. We are going to a Medicaid-only system. When you say HK billing, if you mean rehab, then that would be billed separately. And we've been talking about, instead of a bundled per diem rate for those services, they have to be billed on an encounter or a la carte, if you will, basis.
Will you be having Kipro doing service plans for individuals under the PSRB and secure settings?
Not in secure settings, I don't think. Well, I don't know.
Service plans for PSRB. We'd have to take a look at that.
Yeah, we need to, yeah.
Do you only want referred clients who have been accepted, waitlisted on the spreadsheet, or do you want all currently referred client regardless of referral disposition?
Yeah, that's a good question.
Yeah, that is a good question. For right now, it's anyone who is on the wait list. But we're trying to get an idea of the client flow and referral process through this as well. So let us refine that over time. But for right now, at very least, those who are on the official wait list.
Referrals are sent to all programs, so all programs would be reporting the same clients on the wait list. Is this accurate?
Well,
Wait, there's still
referrals
more
sent to
that
all
question.
programs.
Hang on.
Yeah.
There's a separation between those referred and those waitlisted or approved. Does this mean that the program, once approving the referral, would list this? Or are you saying that we still would list all youth referred, which the state receives this information?
Youth. Well, you're talking about a different process for the youth program.
So, yeah, we can bring this back to the kids team. You know, in the adult world, I think it's safe to say that we want to try and move past the practice of what I refer to as shotgun referrals, where you send multiple referrals on an individual to different programs. Yeah. There's like this really is kind of dependent on a couple of moving parts, right? And I go back automatically to the person-centered service plan. And if we are doing good person-centered service plans, we should be very clear in what sets of services that those individuals need, and hopefully would be minimizing the shotgun multiple referral approach.
And that's why I gave the example of 3 programs. I know that the youth program has a different process. And so until, I guess how I would answer that right now is that until the client is referred to a specific program, they're not on the list yet. Once they're referred to a specific program on any sort of wait list, then they're on there. If they happen to be referred to all of them by the kids team, then they're on everyone's wait list. That's just how we should use the form.
So there's 2 more questions, but we have 5 minutes and 6 slides left, so.
Okay.
So,
you know,
about templates?
yeah, some of these questions, I think what we're going to need to do is take them back. They're getting more thoughtful, and
Yeah.
as you guys are asking them,
Which
so,
we appreciate.
and we want to answer all these questions. But I think in order to get through this, and some of us have to be at another meeting, I think some of the questions now we're going to have to caucus on and send out
We can do that.
the replies.
Yeah.
All right.
Okay.
And actually, the rest of these slides are just reference. They can go pretty quickly. This slide was in the May 21 presentation, and I wanted to remind folks, now that they have their final rate letters, understand that on this plan of care, what we're going to work with KeyPro to do is, depending on the client and the LSI you're providing by tomorrow, we're going to put the tier rate in, give it to KeyPro, and they will put that amount in the plan of care. So that will be the amount that you bill in the dollars for the individuals per diem. So we will preload that that's the rate that MMIS will know to pay based upon the data that you give to us tomorrow. So wanted to reinforce that to you today. And then the rest was just what are the remaining pieces. On the slide 30, I wanted to just remind folks, for the community partners and for any providers direct billing that might be invoicing, Kelly Knight is doing a invoicing training on the 24th of June. And then we will do the next webinar, which will do the billing refresh. We will talk about the details of how to claim on do a prior authorization for the retainer payment for what we formerly called reserve service capacity payments, and any other questions before the July 1 go live. We will want to, I think, continue to have a monthly call or webinar to check in with you all and be able to do this chat and do some question and answer and probably some other kinds of things for best practices. So your thoughts as we go forward, trying to improve the system together, it's much appreciated. The resources are on the last page. We are moving the capacity and the retainer payments to the ABH residential capacity reporting email because it's operational. Some of the, I don't know, we haven't talked yet about the rate review, whether we'll still use the mental health residential, so we can just get the right buckets of work to people differently. And please go back to the website, rate standardization, and in your spare time, review the December 5 presentation if you have any questions about how we develop the rate, and then we'll follow up on those. And we'll get back to you on the other questions around the template.
And thank you for all the thoughtful questions.
Yes.
Thank you, everyone.
Great work. Thank you, Michael. Thank you, Rick.